So, a very good afternoon to every one of you, and welcome all of you to the CCR of Department of Medicine, Unit 1, titled Citing the Right Trees in the Forest, Story of a Vexed Patient. So, the case would be presented by Dr. Ankush, and then it would be reviewed by Dr. Ashwin, with the help of other departments like Department of Radiology, Nuclear Medicine, and Hematopathology. So let's take you all to the journey how we cited the right tree among the forest. So welcome, and Dr. Ankush, over to you.
Thank you, sir. So without any further delay, let's start. So he is a case of 52-year-old male who is a resident of Samastipur, Bihar. He is an organic farmer by occupation and patient does not have any prior comorbidities. He presented with chief complaints of intermittent fever from 5 months with nodular swelling over extremities from 15 days. After reviewing the previous records, we realized patient was apparently well till August 2022 when he had fever and cough for 15 days, for which he was started on ATT based on IGRA test and lung radiology, which showed right middle lobe consolidation. However, after 15 days, patient stopped ATT because there was no response in fever, and subsequently patient developed painful swelling in the left periorbital area associated with left side of the neck, for which patient was treated on the lines of preseptal cellulitis with antibiotics, to which the patient responded and became asymptomatic for 2 to 3 months. However, in February 2023, patient had recurrence with fever, headache, left lower limb and neck pain, and left eye redness and swelling, for which patient was again treated with antibiotics based on the previous history and was evaluated on the lines of cerebral venous thrombosis with MRI, which showed possibility of meningitis. However, CSF was completely normal. To the treatment, patient responded, but the fever still persisted and there was new onset nodular swelling, for which patient was referred to AIIMS for further evaluation and management. On presentation to AIIMS Medicine OPD in February 2023, patient had intermittent fever from 5 months, which was associated with dry cough, weight loss of 4 kgs in 3 months, and nodular swellings over extremities. Although patient had dry cough, but there was no history of shortness of breath, chest pain, or any other cardiovascular symptom. There was no history of GI, GU system involvement, or nervous system involvement. There was no history of oral or genital ulcers or any connective tissue disorder. There was no history of TB in the family or any long-term drug intake or any travel history. On examination, patient's vitals were normal. There was pallor, lymphadenopathy was absent, and there was multifocal nodular firm swelling on bilateral upper limbs, left lower limb, and left supraorbital area. So based on history and examination, we kept the differential diagnosis as partially treated bacterial or opportunistic infection or disseminated granulomatous disease, for which patient was admitted to medicine ward for further evaluation and management. On admission, patient had hemoglobin of 7.7 with slightly raised MCV. In anemia workup, patient had normocytic normochromic anemia with occasional macrocytes and there was no evidence of dysbiosis. Other anemia parameters were normal. Apart from hemoglobin, other cell lines were normal. Serum RFT and LFT were normal, except the presence of hypergammaglobulinemia, for which myeloma screening was done, which did not show any evidence of monoclonality, and inflammatory markers were significantly raised. So for the characterization of the swelling, ultrasound of the local extremities was done, which showed that superficial thrombophlebitis, and incidentally it detected right axillary vein thrombosis, for which thrombophilia workup and DIC profile was done, which was normal, and patient was started on enoxaparin for deep vein thrombosis. So after thorough history, examination, and basic investigation, we have an elderly male who presented with fever for 5 months with superficial thrombophlebitis and deep vein thrombosis, and on evaluation, patient had anemia with raised inflammatory markers and polyclonal hypergammaglobulinemia. So till now, we kept a differential broad, which were malignancy, chronic infection likely granulomatous, or autoimmune disease, for which further workup was done. For malignancy, SOPT was positive, so we did upper GI endoscopy and colonoscopy, which were normal. So obviously, next step was to do a PET scan. For autoimmune workup, ANA, ANCA, MPO-PR3, and other workup were normal. For infection, chest X-ray showed GGOs in the right upper lobe with right pleural effusion. However, sputum examination was normal, and blood and urine culture was sterile, and echo was not stressed or any infective endocarditis, and other chronic infections were also normal. So we did a PET scan. So now I would like to call Dr. Kunal for discussing the PET scan findings.
So this patient underwent a FDG PET CT at our department on the 22nd of February 2023 as we can see, the most striking image on the maximum intensity projection image or MIP image is that there was diffuse increased FDG uptake in the visualized marrow. Further, another thing on the MIP is that the spleen has more FDG uptake than the liver, which is not usually the case. This is an indirect marker of ongoing systemic inflammation irrespective of the etiology. The transaxial fused PET-CT images showed that there was increased FDG uptake along the bilateral subclavian veins with no obvious filling defect in our study. There was also increased FDG uptake along the portal vein and the bilateral femoral veins. In the lungs, there were FDG event ground glass opacities involving the right middle lobe and right lower lobe. We also found an asymmetrically enlarged right palatine tonsil with increased FDG uptake and few subcentimetric FDG event cervical lymph nodes. There was also subtle soft tissue thickening in the paraesophageal and right paratracheal region with no definite mass lesion, which showed increased FDG uptake along with few FDG with subcentimetric mediastinal lymph nodes. So the final impression was that there was increased FDG activity along the different veins as described, which was consistent with thrombophlebitis. The findings in the lungs, they were likely of infective or inflammatory etiology. There was an enlarged right palatine tonsil with increased metabolic activity. And there was diffused FDG uptake in the marrow, which was consistent with the secondary to the severe anemia that the patient had. Also, we found borderline hepatomegaly, but there were no focal lesions. Back to Ankush.
Thank you, Dr. Kunal. So while we are evaluating the patient, the fever persisted and there were 2 to 3 spikes per day with maximum temperature reaching up to 102 degrees Fahrenheit. And interestingly, nodular swelling dissolved. And we noticed that there was predisposition to thrombophlebitis on cannulation as well as the sampling sites. So from first PET scan, we had the following 4 leads. First was uptake in the right palatine tonsil, from which we did a biopsy, but it was unremarkable. However, after 1 day, patient developed painful left neck swelling along with tenderness in the tracheal rings. So we planned a CCT neck. Second lead was uptake in the paraesophageal and paratracheal tissue and mediastinal lymph node. However, due to the small size, none of the site could be sampled. Third was phlebitis in the bilateral subclavian, portal and femoral veins. And fourth was a lung parenchyma involvement. Outside CT showed that it was right middle lobe, now which has progressed to involve right lower lobe as well. So we planned a CCT chest for its better characterization. So now I would like to call Dr. Priya for discussing CT findings.
Good afternoon. So we have the CCT chest dated 3rd March 2023 for this patient. These are the lung window images. We can see that there are bilateral patchy GGOs in both the lung fields with no specific predilection. Compared to the prior PET scan that we saw in February, there is significant resolution of the ground glass opacities which were in the peribronchovascular distribution. Apart from that, there were subcentimetric mediastinal nodes as also seen in the PET scan, which were not significant, and chronic post-infection sequelae in the lower lobe in the form of fibroatlectic changes, as we can see here. Following that, there was a CCT neck dated 5th March for this patient. So here we can see that there is pharyngeal mucosal space on the left side appears bulky, as seen here. Coming further down, even the medial pterygoid on the left side is bulkier. Then the left tonsillar fossa is significantly bulky compared to the right side, although the parapharyngeal space appears to be preserved. Further down, the submandibular gland is diffusely bulky on the left side with no obvious focal lesion. Again, the submandibular gland is bulky. On the coronal, we can appreciate the asymmetry between the two sides. So, on the left side, the pharyngeal mucosal space, there is diffuse bulky soft tissue along the mucosa. And even the parotid glands are asymmetrically bulky, which is also shifted from the right palatine tonsil in the PET scan to the left tonsillar fossa in the current CCT neck. So, I would like Dr. Ankush to continue.
Thank you, Dr. Priya. So from CT findings, we had the following leads. First was the lung involvement. There were bilateral GGOs in both the lungs, right more than left. So the possibility of BAL was discussed. However, due to the pattern of lung involvement and minimal findings, the procedure was deferred. Second was lesion in the left tonsillar region. So FNAC was done from it and it showed only reactive changes. However, on next day, patient developed new onset tender left cheek swelling. Third was left submandibular style adenitis. So to rule out other exocrine gland involvement, Shermer's test was done, which was positive. And again on next day, patient developed tender left periorbital swelling, which progressed to involve entire eyelid within 1 to 2 days. So we did CMRE head and neck to rule out any lymphomatous hyperplasia or any infective etiology. So now I would like to call Dr. Priya again.
So we have the CMRI dated 15th March for this patient. So again, we can see that compared to the prior CT scan that was done on 3rd March, now there is new onset left preseptal edema, which is hyperintense on the T2 fat set images. And apart from that, even in the extracorneal superior orbital location, we can see there is mild periorbital edema. But the retroorbital fat was spared, bilateral optic nerves appear symmetrical, and bilateral extraocular muscles also appear symmetrical and normal. Apart from that, there were evidence of bilateral ethmoid sinusitis, no evidence of contrast enhancement, significant enhancement, or diffusion restriction within this edema. So also appreciable on the corneal images. This was contiguously extending even in the retroentral fat. Here you can appreciate the asymmetry on the left side and also in the left floor of mouth. As we can see the hyperintensity along the mylohyoid muscles as well as the submandibular gland. Again, no significant enhancement or no evidence of any organized collection. So we kept a possibility of inflammatory change only. Even the nodes were not significant. Just the inflammatory, or it could also represent an early infective etiology. Dr. Ankush to continue.
So till now, during the hospital course, patient had developed various swellings. First was painful left neck swelling, which was developed after right palatine tonsil biopsy. Second was left cheek swelling, which developed after biopsy from left cervical lymph node. Third was periorbital swelling, which developed after Shermer's test, and these swelling tended to resolve within few days, likely NSAID response or self-resolution. And after extensive evaluation, we could not find any infective etiology, so we considered that these swellings are inflammatory in nature, which used to get provoked by trauma, like the pathology phenomena that we normally associate with Behçet's disease. However, there was no history of oral or genital ulcer, and HLA-B51 was normal. So till now, we did not have any diagnostic clue, and also patient had disproportionately severe anemia along with raised MCV and polyclonal hypergammaglobulinemia. So we went ahead and did a bone marrow study. So now I would like to call Dr. Shreyam for discussing the bone marrow findings.
Good afternoon, everyone. We have received this patient's peripheral smear as well as the bone marrow aspirate and biopsy. In the peripheral smear, there was rouleau formation. You can see in the lower power as well as in the higher power. There were some lymphoplasmacytic lymphocytes. Which you can see in this image, as well as some neutrophils showing minimal vacuolations. These vacuoles were there, but they were very less in number. And the same findings were there in the aspirate slide also. It was aparticulate, hemodiluted. We saw some vacuoles in the neutrophils, as well as this is in the higher power, the same neutrophil you can see here with some vacuoles. This finding was there in the aspirate. The bone marrow biopsy was hypercellular for the age. It was 60 to 70% of overall cellularity. Though it was inadequate for an overall opinion, but we found out there are plasmacytosis constituting approximately 11% of all nucleated cells, as well as there was trilineage hematopoiesis. Till this point, we have rouleau formation, which is due to this polyclonal hyperglobulinemia. We have some vacuoles in the neutrophils, as well as some plasmacytosis, which is probably reactive because they were polyclonal for kappa and lambda. Now we'll hand over to Dr. Ankush.
So from again bone marrow, we did not have any diagnostic clue. So we reviewed the case again. So our case is an elderly male who presented with fever from 5 months along with venous thrombophlebitis and deep vein thrombosis. And during the hospital course, patient developed multifocal sterile swellings. On evaluation, patient had moderate to severe anemia with markedly raised inflammatory markers with minimal vacuolations on bone marrow biopsy. And the initial diagnosis we kept were malignancy, infection, and autoimmune. But after extensive evaluation, they seemed unlikely. So we consider the possibility of rare diagnosis, that is autoinflammatory syndrome based on fever with systemic inflammation, multifocal sterile swelling, with no evidence of malignancy, autoimmune, and infection. These syndromes are characterized by unchecked activation of innate immune system, resulting in localized or systemic hyperinflammation. And these are categorized into various types based on the pathway involved, like inflammosomopathies or interferonopathies. However, after deep review of literature, our patient did not fit into any particular phenotype. So we considered the possibility of undifferentiated autoinflammatory syndrome, and for that NGS panel was sent. While awaiting the NGS panel, our decision was taken to start steroid, and before starting steroid, a repeat PET scan was done to ascertain the burden of systemic inflammation and for better assessment of treatment response and follow-up. So now I would like to call Dr. Kunal again.
So this patient underwent the second PET scan at our department on the 17th of March. As we can see on the MIP image, the diffusely increased FDG uptake in the marrow was persistent. Also, the spleen again is hotter than the liver, suggestive of ongoing systemic inflammation. Interestingly, the increased FDG uptake along the bilateral subclavian veins that had resolved in the current study. However, we noticed that there was increased FDG uptake along the bilateral common carotid arteries, as we can see in these sections, and also along the arch of aorta anteriorly. Further, there were few variably FDG avid mediastinal lymph nodes, that is, some being FDG avid and others not being FDG avid. There were also some other subcentimetric variably FDG avid nodes in the periportal location, in the retroperitoneum, and in the bilateral inguinal regions. In the current study, the lung involvement had now progressed from just the right lung, middle lobe, and lower lobe to also involve the left lung, as we can see. These GGOs, which are FDG avid. So the final impression was there was resolution of the phlebitis, but in the current study, we had variably FDG avid subcentimetric lymph nodes, which were in locations such as the cervical, mediastinum, and retroperitoneal location, and periarteritis in the form of increased FDG activity along the arch of aorta and at the origin of the bilateral common carotid arteries. So with this, we had suggested that a possibility of IgG4 related disease needs to be ruled out. Further, as already mentioned, the lung changes had progressed to now involve both the lungs. Back to Ankush.
So second PET scan came as a shock to us because there was resolution of phlebitis without giving any immunosuppression, and there was new onset periaortitis and periarteritis. Based on this PET scan finding, we considered the possibility of IgG4 related disease, and even though there was presence of salivary gland involvement and elevated IgG4 level, but the presence of fever and raised inflammatory markers goes against the diagnosis, and also the histopathology was not suggestive of IgG4 related disease. So we started the patient on low dose steroid, after which patient became afebrile within 24 hours with the resolution of the periorbital swelling and improvement in the appetite and general well-being. So after this, patient clinical condition improved, and we discharged the patient on prednisolone 20 mg while awaiting the NGS panel report. So NGS panel report came after 1 month, which showed this mutation in the UBA1 gene with mutant allele percentage of 59.7. So this clinched the diagnosis that he is a case of Vexed syndrome who presented with fever, bilateral GGOs in lung, anemia, multifocal inflammatory swelling, and thrombophlebitis, periarteritis, and periaortitis. So after giving steroid, there was resolution of fever and inflammatory swellings, but the CRP was still elevated. So we decided to give a second steroid sparing agent, and after review of literature, JAK inhibitors are the preferred one. But however, tofacitinib is known to cause thrombotic manifestations in elderly male. So after shared decision making, a conventional DMARD was given, methotrexate, after which CRP values became normal, and there was no new onset fever or inflammatory swelling. And the repeat PET scan done after 6 months also showed the complete resolution of the activity, and there were decrease in the splenic uptake, which is a marker of systemic inflammation. So currently, after 1 year of the disease, patient is completely asymptomatic on prednisolone 2.5 mg and methotrexate 20 mg. So now I would like to call Dr. Ashwin for the discussion part.
So good afternoon. This entity was first described in 2020 in the seminal article published in NEJM by David Beck and his team from NIH Maryland. So they adopted a genotype first approach wherein they had a database of patients with undiagnosed periodic fever syndromes from where they suspected mutations in the ubiquitination pathway. And they found some patients with mutation in the UBA1 gene. Post which they clustered these group of patients with the clinical entity labeled as Vexed syndrome, where V stands for vacuoles. Now, vacuoles can be present in myeloid and erythroid precursors in almost all patients, but however, they're not specific to Vexed alone. They can be present in alcohol abuse, copper deficiency, zinc toxicity, and myelodysplastic syndrome. More the number of neutrophilic precursors with greater than one vacuole, there is increased sensitivity and specificity to the diagnosis. These are sets of cohorts now that have reported Vexed syndrome. Now, over time, you can observe that there have been cohorts that have reported cases with less or minimal vacuoles. And our patient also falls within that category of minimal vacuolation. So now looking at the E1 enzyme, which is the ubiquitin activating enzyme encoded by the UBA1 gene, which is on the X chromosome, and this entity mainly affects men. But however, it has recently been reported in women as well, the possible mechanisms being X monosomy and uniparental disomy. As far as the mechanism goes, the UBA1 mutations occurs on the X chromosome, and the E1 enzyme is responsible for protein degradation. Now, when there is faulty protein degradation, these proteins accumulate in the cell, causing an unfolded protein response. There is ER stress, which results in hyperinflammation and increased cytokines, which leads to the myriad of manifestations of autoinflammation. Now, autoinflammation manifests as unchecked activation of the innate immune system with recurrent attacks of fever involving the skin, joints, lungs, blood vessels, and multiple other organs. One needs to keep a high index of suspicion for systemic autoinflammatory diseases once we have ruled out infections, systemic autoimmune and rheumatoid diseases, and malignancy. Though these disorders are commonly reported in pediatric patients, adult onset diseases are not uncommon. Now, some of the classification of SAIDs are that it's monogenic or polygenic or mixed. And among the monogenic disorders, as Ankush had previously described, there are inflammatoropathies, interferonopathies, dysregulation of the nuclear factor kappa B, and Vexed syndrome particularly falls under protein misfolding and endoplasmic reticulum stress. Now, as far as the clinical manifestations of this syndrome goes, the initial cohorts predominantly described the entity in men, and they reported fever, skin manifestations with predominantly nodules and neutrophilic dermatosis, pulmonary infiltrates as shown, arthralgia, chondritis, vascular thrombosis in about 45% of the patients, and vasculitis. So, vasculitis was predominantly giant cell arteritis, leukocytoclastic vasculitis, and medium vessel arteritis reported in multiple cohorts. Now, periarteritis and large vein phlebitis hitherto remain unreported. This was seen, however, in our patient. Now, over time, the clinical manifestations have been evolving. Now, if you observe here, now with time, patients have had worsening anemia and have gone on to become transfusion dependent, progressing to MDS with single lineage dysplasia, more vacuoles present in the marrow, and worsening thrombocytopenia. Now, as far as the mutations go, this is a somatic mutation, and they occur in cells other than germ cells. So, they're difficult to pick up. And the changes are present only in a fraction of cells. Based on retrospective exome data analysis, these UBA1 pathogenic variants were present in about 1 in 13,500 patients. Now, why are these mutations important? For example, this particular mutation and of replacement of methionine with valine at the 41st position portends a poorer outcome. This mutation was also seen in our patient, who is, however, doing well as of now. Now, why is it important to pick up Vexed syndrome? It predisposes to hematological malignancies like myelodysplastic syndrome and increases the risk of multiple myeloma as well. Persistent and progressive hyperinflammation can result in organ failure and high mortality rates up to 40%. So, what are the treatment options currently available? Worsening hematological disease, and if the patient is suitable for hematopoietic stem cell transplant, that is the way to go. But otherwise, low-dose methylprednisolone is the linchpin of initiation of treatment. For rheumatological manifestations, we have anti-IL-1 therapy, anti-IL-6, tocilizumab, and JAK inhibitors, which are showing some benefit. In hematological predominant disease, azacitidine has shown some effect. Now, these are the multiple agents that have been tried in different studies reported. There have been some studies that have used DMARDs and methotrexate, albeit unsuccessfully. However, our patient is in remission with methotrexate, which warrants study of particular phenotypes that can respond to certain drugs. So, with that, we need to understand that Vexed syndrome manifests as an adult onset, predominantly autoinflammatory disease with MDS mostly in men. The clinical spectrum is still evolving with newer phenotypes being reported, and our understanding of the disease pathogenesis is improving with time, and treatment strategies for Vexed syndrome are a work in progress. Thank you. I would invite Dr. Siddharth Jain sir to give his expert comments.
Thank you, Ankush and Ashwin, for beautifully depicting the case. So, autoinflammatory syndromes are a new kid on the block. So, the term itself was first proposed just a couple of decades back from NIH. And over time, our understanding of autoinflammatory syndromes has dramatically changed. So, from our initial perception of them being hereditary periodic fever syndromes, where patient would come, fever which will come and go, periodic fevers. Now, the spectrum has dramatically changed to them being syndromes which are causing sterile inflammation, either in single organs, meaning to say that can present to any specialty, which is sitting here, or it may be multifocal involving multiple organs, or it may just be presenting with fever, elevated inflammatory markers without any localization. Our traditional concept was autoinflammatory syndromes are predominantly diseases of the pediatricians, but this changing spectrum has entirely tilted the balance in favor of this being probably more of an adult disease. And as this disease clearly manifests, that this is even much more common in the elderly. So these patients are floating around mostly as undiagnosed patients, and our department is making a cohort of these patients, and we have the entire spectrum varying from Schnitzler syndrome, Dada to CRMO and everything, meaning to say that a sense of awareness or understanding of the existing of these disorders is important. Knowing when to suspect them and when to evaluate them is important. So we don't start thinking of them at the word go. So our initial common diagnosis of malignancies, infections, autoimmune diseases are still central. But if the diagnosis remains elusive despite extensive evaluation, that is where our antennas should get raised, and we should start working them up for these disorders. Genetic diagnosis has a role in a small subset which are monogenic, like in this case. And we have, because these testings are quite expensive, we have some departmental projects which allow testing for these genes which are otherwise very prohibitive because of the cost. As far as Vexed is concerned, it just came into being 3 years back. Lots of cases have flooded over time. As far as India is concerned, we have 4 cases so far, 2 from our center, 2 from PGI. Again, single organ inflammation or multicentric inflammation, multi-system inflammation. The diagnosis becomes easier when we see florid vacuolation in the marrow. So the 3 other cases that have been reported in India, florid vacuolation, and almost everyone now recognizes florid vacuolation in marrow, think of Vexed. However, if the vacuolation is absent or minimal, like in this case, that is when the game becomes difficult, and assessment, unless we do a confirmatory genetic test, is impossible, and unless we attain a definitive diagnosis, giving a definitive therapy, choosing the steroid sparing agent becomes very difficult. So with that, and finally, I would probably want to conclude by saying that these patients cannot be managed without concerted efforts from multiple specialities, as we have already discussed. And I would like to acknowledge the help of all the departments who were involved in the management of this patient, and would open the house for discussion and comments from everyone, including the specialities who were involved in the management of this case. Thank you. I would also want invite comments from Sinha sir.
Very well presented, and congratulations to Medicine Unit 1. Inspector will take some questions if we have any question. Anybody want to comment?
During COVID time, we are all innovative, and we have from medical science, which is imperfect science, we are trying to be more perfect using NGS and other things, genetics. That's very good case, and that shows what All India Institute is all about, where everybody works for the patient to find out the solution. But lately I am seeing all these esoteric type of titles. You are looking for the tree in the forest. You will be only always look for the tree or the animals, you will say, nothing else will. So you could have given this case title as recurrent fever with nodular skin disease. What wrong would have been? Why these esoteric names? I don't know. Lately, last 3-4 years, all you see, undergraduates should have been very happy to come and listen, or even postgraduate to know if a patient comes with recurrent fever, how the medicine department is working on this. It would have been much more informative. Even AIIMS, they write even today, a 68-year-old male presented with recurrent fever, and this is the challenge. So why we have to become more literary? Medicine is just say it is a recurrent fever with a nodular disease. That would, a lot of students would have been, you don't know what they are going to talk. Some esoteric names. Why this new trend in the medicine? Let the this is for the everybody, starting from the undergraduate first year undergraduate student to the senior most professors. This is for everybody.
So if you give the title simple, which can be understood by everybody, it will encourage a lot of, nowadays it's so thinning in 80s and the 90s when we were students and young faculty. I would say this medicine presentation hall was full. Even some people were sitting on the, but where are the attendants? Even the undergraduate students are not coming. So why these esoteric titles? When I'm little, you can be more literary nowadays. A lot of people, doctors are writing books and becoming Booker Prize awards and other things. The King of Melodies and all this, Emperor of Melodies, something like they're writing. That's fine. But for the undergraduate, we have to should not forget that we are delivering the undergraduate teaching here. If you write recurrent fever with nodular skin disease, how it will wrong would have been? Just my argument.
Thank you, sir. We take this as a next time we will be careful. We just try to make it interesting so that it's more eye-catching, more people read, and maybe that can attract. Because anyway, if we write a simple thing, we have seen how the attendance is. But medicine department usually it's full, so it's more of catchy. Yeah.
Dr. Bal and I have a little bit of a right to make these comments because we come for every CCR. And I just want to add to, yeah, and Dr. Bala. Don't start taking attendance. Sometimes I miss it also. But citing the right trees in the forest, story of a vexed patient. Now, the poetry is acknowledged, but why not stop, put a colon after that and say, managing a patient with recurrent fever. Next one is going to be wrath of the mini monster surgery. Once again, have a colon after that and tell us what is the case you are presenting. I don't leave out the wrath of the mini monster. Let's do both poetry and reality.
I think we'll hand over to surgery, sir.